Okay, Doctor, we're gonna get going. Is that okay with you?
Sure, that's fine.
Okay. So I'm gonna just, for all that's present, I'm gonna record this presentation today, as it will be uploaded into our YouTube channel, hopefully by next week. Okay, here we go.
Okay, hi.
Recording in progress.
Let me just introduce Dr. Schoenthaler. Dr. Robin Schoenthaler is an MD, has been following and writing about COVID-19 since the start of the pandemic, who has developed a worldwide following for her weekly post on the subject. During our presentation, she will discuss the state of our knowledge about the disease, how to apply the science of COVID-19, basically getting an update on the variants, the vaccines, the behavior, the lesson learned so far from this pandemic. Dr. Schoenthaler has been a longtime MGH, Mass General Hospital radiation oncologist at the MGH Department of Radiation Oncology at Emerson Hospital, and published an award-winning essayist and storyteller, an obsessed student of epidemics, and the mother of two fabulous young men. Thank you so much, Doctor. We appreciate being with us again. We look forward to hearing this incredible lecture. So the floor is all yours. Thanks for being with us.
Thank you. Sure. Thanks.
Let me share my screen with you.
Yes, please, so I can share back. So I can't share mine yet. It says the host has disabled participant screen sharing.
Yeah,
So if you can just fix it,
Yep.
so at least I can share.
Sure. Come on. You should be able to now. Perfect.
Great. I just want to be able to, I can't quite push my play button. Sorry. There we go. Okay, great. All right. Without further ado, thank you. Thank you for inviting me. Thank you to the people that are here. I honestly thought it might turn out that nobody came. So thank you so much for you guys coming, for wanting clearly the world to be a better educated, safer place, and for being willing to do another Zoom call in whatever circumstances you're in. Fortunately, I'm not in the same circumstances that this woman was in. She went to give a speech during the Houston ice storm and had no electricity. So her kids went out, God bless these kids, and set her up with electronics in her car. I'm doing it from the comfort of my Arlington dining room. But God bless my kids who have supported me in all this, just like her kids. So yes, our agenda is going to be include learning about COVID and not freaking out, vaccines, variants, behaviors, and the lessons learned. I think an incredibly important question to ask me right from the start is, why am I talking about COVID? I am a Boston cancer doctor. I had worked at Emerson for all those years, but I'm not an infectious disease doc or on the front lines or any of the kind of specialists that have helped us out so much. And I think it's really important to ask people what their credentials are when we're learning about something like COVID. What my credentials are is that I'm a longtime student of epidemics, mostly because the whole time that I was in medical school, I was treating HIV and AIDS patients. So I got deeply into the history and the presentations of pandemics all for my entire medical career. And I've been consumed by COVID from the start, from the very, very first day. In fact, we got shut down in Boston, in Massachusetts on March 13th. But I sent out my first Facebook advisory notice about COVID on March 6th. I continued to write weekly on Facebook and other platforms ever since. So I now have about 70,000 words from about 60 posts up to and including this last weekend. So the question arises, how does one get educated? How did I get educated about COVID, even though I'm not an infectious disease or epidemiologist specialist? Well, I learned the same way that doctors always learn. I learned from people that were smarter than me. I learned from people that had more experience, physicians and scientists and what I call credible interpreters. I really did not learn much and don't recommend learning from the mainstream press and not from YouTube non-experts. What that has done for me, hanging out with doctors and physicians and people that are educated about the pandemic and educating about it, is that it's meant that I've been hanging out with problem solvers. I think this is an incredible differentiation between hanging out with people that are trying to solve the problem that we're faced with, rather than people that are trying to publicize it. And secondarily, it's led me to have just really very high levels of optimism throughout all of this. I always felt the science would win. I always felt that all epidemics always end. And all of that has turned out to be true, despite the many obstacles thrown in our way. So how did I learn? I mostly learned online. And I'm going to show you some of the places where I learned and where you can learn and where maybe we'll turn during our next pandemic. I learned from people like this. This is an older group of virologists who have a hilariously funny, very scientific YouTube show. It's called This Week in Virology. Their tagline is This Week in Virology, the show all about viruses, the kind that make you sick. And then it goes bum, bum, bum. What they are is basically 5 or 6 people plus guests that sit around for an hour or two and talk about the news in viruses. So this was an incredibly great way to hear what was going on that week in virology. And they also had special guests, so I'll talk about in a minute. And they also have a once a week clinical update from Dr. Daniel Griffin, who's a New York, exactly what I'm not, infectious disease epidemiologist, PhD and ICU doctor that takes care of COVID patients every day. So every week he would give an update in the treatment of COVID patients. So that was another great source of learning. There's on YouTube, there's a great update once or twice a week from a group that started out doing phone studies on GI issues and then pivoted to do work in COVID. They have great shows every week. There's a nurse, a PhD nurse in Britain who has a beautiful British accent and gives great data-based analyses every week. There's grand rounds that are doctors talking to doctors across the country. And it used to be that you could only be there if you could be there in person, but now the UCSF grand rounds they're all on YouTube. You can listen every week. UCSF themselves has had over 2 million listeners. So these are another great way to learn. And a group called MedCram. There's a bunch of great sources. And after a while, I started learning who I really wanted to listen to. One of them was Dr. Shane Crotty, who's a famous virologist. Paul Offit, who's a guy who's invented vaccines. He's a pediatrician at University of Pennsylvania. So there's all kinds of super great experts. And then, of course, I had access to the New England Journal, American Medical Association, all that. But even for what I want to emphasize is that even for lay people, there's tons and tons of great resources on the internet, as well as what I call COVID translators, who are scientists and physicians like me who have found their niche during the pandemic to be translating to the lay public. So there's like a great group on Facebook and on the internet called Dear Pandemic. It's a group of what they call themselves nerdy girls. It's an all-woman team. In fact, a lot of these translators are all women. That has like a Dear Abby column on the internet and on Facebook where you can send in a question about how to handle something with COVID and they'll answer it based on science. A number of epidemiologists have set up their own websites. This is my favorite. This is a PhD epidemiologist in the Deep South. She's smack in the middle of the Bible Belt. She's taken a love your neighbor approach to epidemiology and COVID protection and has single-handedly been responsible for church safety at literally hundreds of churches in the Bible Belt. She has my greatest of admiration. So basically, I consider this coping with the fire hydrant of information and misinformation to be a really critical skill to have in this kind of an emergency, and really emphasize the importance to lay people of sticking with science-based media and trusted writers, and maybe even setting limits on how much you're willing to take in. Because I think if most of us think back to those first horrifying months of being constantly on the internet or constantly watching 24-hour-a-day news and doom scrolling, I don't think it was good for any of us. And I think we all need to factor in the psychology of information overload and misinformation. Because we know that the impact of constant news, particularly constant bad news, has a number of bad effects on us in terms, there's been studies that have shown impacts on blood pressure, impacts on enforcing isolation and pessimism, particularly with disinformation. And it's just not a resilient way to cope with this kind of a emergency. And I think when it's all said and done, there's going to be 10 billion papers about all aspects of the pandemic. But I think a huge thing we're going to discover is just what a huge impact it had on us psychosocially. We already have clues that, the incidence of depression, suicidal ideation, isolation all went up. These are Google searches for the word depression during the worst of the pandemic. We've seen when you ask people how happy they are, particularly young people have really had a miserable time of it. Young people in their 20s whose lives have been so disrupted, and people in their 30s with small kids, it's really, really been tough. Older people have different levels of resilience and different challenges, so it's been different, but still very tough. We've seen some pandemic behaviors become more dysfunctional. We've seen, they said that alcohol sales in the first 6 months of the pandemic went up 200%. That's leveled off, and we actually have some people that became teetotalers during the pandemic, but certainly we've seen issues with alcohol, substance abuse, and weight and food intake. What we have not seen, interestingly, one behavior that has improved during the pandemic has actually been sleep. People have slept more and slept better after the first couple of months than in the past, which is really interesting. And I think probably has a lot to do with the commute, but and also a lot of people not working. But it's been an interesting finding. But certainly we know that right from the start, we were all glued to our computers with better or worse effects from that. And that's basically because bad news sells. We know this. And we know that many of us were in danger of becoming like this guy who basically fell asleep laying on top of all his cords. You can see he has his headphones, he has his USB cord, he has all his cords that are like embedded in his skin. We don't want to be that guy. So just as kind of a funny little guidance, I just want to point out one of the ways that bad news sells on both the internet, where they want more clicks, and in the newspapers and magazines where they want more subscriptions, is that they've had almost, I would say 95% of articles are what if articles. What if this variant gets bad? What if people don't wear their masks? What if? They've all been preliminary scientific findings as opposed to definite ones. So I have a little guide here for words that you can spot where you know that means you should probably stop reading, because it means it's not found in science. It's something either preliminary or something that people are afraid of. So if you see somebody that's written an article that says there's a preliminary finding, you have my permission to stop reading. Or scientists wonder, you can stop reading. Or raises the question, or far from a far gone conclusion, totally stop reading it. It's just some kind of fear mongering. Or signs suggest, or researchers still question, or this development might be a potential blow. Trust me, I don't want to read about a blow until it's really a blow. I don't need to worry or think about potential blows. Now, I do think that if you read the Boston Cancer doc who writes about COVID, which is me, then maybe it's okay to keep reading. But all these others, I really I just find that they're red alerts that what you're about to read is only going to instill fear and not facts. All right, let me just talk for a minute about the good news. This is the good news. This is what's happened in the United States since the pandemic started. When the pink slope starts to go down, that's when we got vaccines. That's the good news, is that the science is going to win. The science is going to get us out of this. And we can see it really visibly in all of these graphs, which include this incredible decline in cases at the top, hospitalizations in the middle, bottom, and deaths on the most important thing on the right. We still have just passed 600,000, which is absolutely crushing when you think of that. And when Fauci said it early on, maybe it would be 150,000, and everyone was so horrified. And to think that all of this catastrophe is caused by this simple little structure. In every talk I give, I always just want to show this because it's just beyond belief that this tiny structure that has this little yellow chain of mRNA chromosomal information sitting in a blob of butter with some proteins spiked into it has caused all this. It's such a simple thing, it doesn't even have a brain. It's not nearly as complicated as a bacteria. It's nowhere near as sophisticated as a cell. And it just looks like this in real life. And yet all of our lives have been affected for all of our lives by that simple little thing. This is what it looks like in Massachusetts. Just like in the United States, we had some surges, and you can see how incredibly well it's gone down since really you can start thinking about vaccines in January. Another incredibly reassuring slide is this one. This is the Department of Water and whatever it's called in Massachusetts has from the start of the pandemic been measuring the bits of COVID virus and bits of the mRNA in the wastewater. And so you can see this is in January when we were going through that horrible surge, how much viral mRNA was in the wastewater. And this is what it looks like now. It's as close to zero as we're probably going to get. And the wonderful thing about this statistic is it doesn't reflect people's behavior. It doesn't reflect testing. This is just what is floating out there, what people have in their bodies and are excreting. So clearly we're moving, incredibly well in the right direction. I showed you that slide already. But still, this is a slide showing the numbers of deaths from various catastrophes in the United States. This is as of October 26th. It was one of the worst. Unfortunately, this guy hasn't updated his slide, but now you can see that with the over 600,000 deaths that we've now outstripped all U.S. catastrophes in terms of deaths, except for the 1918 flu pandemic and the Civil War. And my bet is, I think most assuredly will end up outstripping the 1918 flu epidemic. So what we have lived through will end up being the worst catastrophe, the worst non-war catastrophe in American history in terms of American deaths. It's also very important to note that this is probably not the last time in our lifetimes that we're going to see this kind of a pandemic. So it's incredibly important that we learn from this one. What this arrow shows is that since 1200, there have been 4 coronaviruses that had what is considered to be the potential to turn into pandemics. Only 4 times in 800 years. But in the last 18 years, we've had 3. This is because we're around animals more, because of climate change, because so many of us live in cities. I mean, there's a whole bunch of reasons why it's happening. The fact is that it's happening. Let me talk about variants, because I know this is on everybody's mind. I want to start out by saying viruses love to mutate. That's what they do. Viruses, and so the coronavirus has mutated a billion times. This is from long ago. This is from January. This is 5 months out of date. Show each one of those dots is a variant. Utterly inconsequential. None of them have had any major, or virtually none of them have had any major impact. And if we had the slide go out to June, it would show an equal number, maybe even more variants. Just showing you this to get across the fact that variants exist They're normal. Viruses love to mutate. Virtually the vast majority of the time that they reproduce, they create a mutation that can create a variant. They do it all the time, but it's a survival of the fittest thing. Most of them, since only the strong survive, 99.99999% of variants are irrelevant. Just for a second, let me remind people how we find out if somebody has a variant. How do you find out if you have the virus, period? Somebody puts a swab in your nose or maybe your throat, and they look at your boogers under, they put it in a machine and test to see if you have pieces of the virus. That's how you find out. It's simple, it's fast, it's 15 minutes or it's 24 hours. It's quick. It's a quick, easy test. How do you find out if you have a variant? Much more complex. You have to take that same swab, those boogers, and you have to send it to a specialized lab that has super fancy equipment and a super fancy technician that knows how to run it. And then you have to be able to have the right test for the variant. That's how you find out if you have a variant. So we don't test everybody. We test everybody for COVID, but we don't test everybody for variants. And in fact, that was one of the bad things about the first part of the pandemic, was that we didn't test well at all. Even the CDC, which is set up to do it for flu, this is a common thing that they do for the influenza season to see if it's mutating, but they weren't set up to do it for this. So when Biden took office, the CDC was running like 275 tests a day for the whole country to see if there was variants. Now, assuredly we had variants, but they weren't showing up because we didn't have enough tests to be able to run. Now it's way, way, way more. I mean, the last accurate number I could find was in April, 275,000 tests per day. The CDC is, outsourced a gigantic program. They do some at the CDC, but they use commercial labs and universities and things. And so now we're testing a lot, but still not everybody. I mean, we're still only testing maybe 5 or 10%. What you're looking for, remember this is that diagram of the COVID virus. What you're looking for is in the center, you see that little chain of the mRNA. And on the very outside is the chain of that chromosomal information stretched out. And what the variant sequencing is doing is it's looking at every single one of those proteins in there, looking to see if there is a single mutation. So it's a tricky test, right? Sometimes it's even more complex because there's multiple specific mutations that you're looking for. So it's a big fancy test. And with it, we're able to find out the rate of variance amongst the specimens tested. What happens, though, is that every time they come up with a variant, not all those 50 gabillion that I showed you, but what happens is they see those little dots of variants. And if they're testing a lot, they start to see patterns. And if they start to see a variant, one specific variant start to show up more, they call that a variant of interest. And then if it looks like it has certain characteristics, it gets a promotion. It gets called variant of concern. As soon as you get a variant of concern, the headline writers start losing their minds and start basically every variant of concern and some variants of interest becomes 50,000 headlines using all those words that I showed you. Scientists are concerned, or it's possible that. The way that a variant becomes a variant of concern is that it's more contagious. That's how you start noticing more, because more people get it, you start seeing it more of your samples. So the headlines start saying, it looks like this variant is more contagious, more infectious, more transmissible. And then they leap from the non-scientific mainstream press that wants to sell magazines and everything, leaps to it may become dominant, which sounds like super scary. And could be serious, which sounds super scary. But what's important to recognize is that most variants want to become more contagious. That's what they want to do. They want to be one of the strong, fit ones that, dominates. They don't necessarily want to become more lethal, because then they'll kill their hosts and then they die off. So it's not in a virus's best interest to become more lethal. And in fact, none of the variants of concern or interest that we've seen thus far have become more lethal. We may have seen more deaths because there's more cases, but we have not seen a variant yet become more lethal. And the other thing to recognize in this era of vaccination is that the transmissibility, not to mention the seriousness of it, always is now addressing largely the unvaccinated. New variants are really not a concern so far to you and me because if we're vaccinated, but they're a very big concern if you're not vaccinated. So most of the headlines is useless information saying this could happen, or that it's spreading, or that it's becoming dominant. And maps like this make me crazy because who would ever think that where a virus is on any one given day has anything to do with where it really is or where it's going to be tomorrow? I mean, it's ridiculous. Viruses don't pay attention to state borders, much less international borders. So that's another thing. If you see a map, you can just cross it off. This map, not showing it in New Hampshire, doesn't mean you're safe in New Hampshire. What we really need to know about a variant of concern, first off, I wouldn't even read anything about variants of interest, but if you feel compelled to read about variants of concern, what you want to know is this bug more contagious or transmissible? And the answer is usually yes. That's how it became a VOC. But is it more severe or deadly? As I mentioned, no, they have not turned out to be more severe or deadly, and it doesn't make theoretical sense. Could you get reinfected from it? It's possible, but it has not turned out to be a major issue. Could it escape testing? It has not turned out to be a big issue. We can still find all these variants with our standard testing. The big question is whether they can escape a vaccine. And so far, none of the variants of concern, with the possible exception of Delta, have turned out to be big escapers from our incredibly effective vaccines. Now, as you will probably recall, the vaccines have about roughly a 95% effectiveness, which means 5% of the time you can still get sick, even if you are vaccinated. But for the vast majority of people, they're protected from all versions of COVID by the vaccine. It may be that with some variants of concern, that number goes from 95 to 90 or 85, but it's still the vast majority of people are protected. So the badness is not if a variant becomes dominant, and it's not even if it reinfects, because that doesn't happen. The badness of a variant would be if it had complete escape from the vaccine, and we haven't seen that at all in anything, including Delta. Okay? So no matter what scary headlines you read about vaccines, about variants, we have not seen escape from the vaccine, and that's what counts. So right now, we're okay. All the variants that you've been hearing about and reading 50,000 headlines per variant, the one from the UK, the South African one, the Brazilian one, the California ones, all of them have turned out to not be more lethal and not have escape from the vaccine. Now I'm going to talk about the one from India, the Delta one, but it's still basically the same thing with a few caveats. Okay, but right now, we're basically okay with all these other variants of concern that have each had 50,000 headlines that have all turned out to not be true. So what about the Delta? Okay, it's absolutely more transmissible, yes. So it's definitely going to become more dominant, right? If something is more contagious, you're going to see it more often when you test for it. So having something that is more infectious is definitely going to lead to it being, quote, dominant. It's already huge in India. It's huge in England. It's supposed to be maybe 10% here with our present testing. I have no doubt that by the end of the summer, it will be way higher than that. It will probably be dominant in the United States. It isn't obviously more serious. We're not seeing people die more often or faster. It also seems to be more contagious, specifically in young people who, as you know, don't have such a serious bout with COVID in general. So, and the majority of people that are getting it, certainly in India, definitely in England, and certainly here, most of the people that are getting it are unvaccinated. That is who Delta is a true risk for, are people that are unvaccinated. We're not seeing complete escape from the vaccine at all. We are seeing a little more escape than before, than with the other variants. In other words, we are seeing some fully vaccinated people get Delta anyway. They are, if they're vaccinated with Pfizer and AstraZeneca, still almost never ending up in the hospital, and they're still not ending up dying. But we are seeing a little bit more breakthrough through the vaccine. But still, the vast majority of people that are getting Delta are unvaccinated or they got one shot. The second shot is super critical with Delta, super critical. So again, the vast majority of people are unvaccinated. Some are between shots. And this has really taught us that, unlike the previous variants, the second shot is super critical for this one. The vaccines tested in the lab seem to offer really great protection, but again, it has to be with 2 shots. So some experts are saying it is possible that every unvaccinated person in the United States could get this. Pretty graphic. Now, even if you cut that in half, it's a lot of cases. So Delta is definitely yet another reason to get vaccinated. And again, you have to have both shots. The vaccines that have been studied with Delta are Pfizer and AstraZeneca. Pfizer's great. AstraZeneca is good. Both excellent at keeping you out of the hospital and keeping you from dying. Moderna hasn't been tested, but it has the same mechanism as Pfizer, so it's probably fine too. Johnson & Johnson hasn't been tested, but its mechanism is a lot like AstraZeneca, so it's probably good. It might not be great, but it's probably good. So this brings up, what about J&J? What if you did get J&J? We don't know yet how it's going to do against Delta because it hasn't been studied. But again, we're optimistic that it has a similar mechanism to the AstraZeneca, which has been studied, so it's probably okay. But this is going to bring up the question of whether or not a person that's had J&J should get an mRNA vaccine, a Pfizer or Moderna. And that's being studied. And I will tell you that some doctors have started doing it without any study. I don't think that's a good idea. I think you should do everything based on science, but some people are already doing that, particularly for high-risk people. So right now with Delta, if our listeners are vaccinated, you're good. You're at slightly higher risk than with the other variants, but not huge risk at all. But we are definitely high risk if we're not vaccinated. I do want to remind people that even if we had a variant that went down to 50%, we could still reprogram vaccines. But in the meantime, we just need to think about our post-vaccine behavior in general. When the vaccines first came out, we weren't sure how well the vaccines would protect us from each other and from infection. We had that 95% number, but if we became the 5%, we weren't sure how often we would give it to each other. We weren't sure about how dangerous vaccinated people were to other people. Well, now we're really clear. There are very, very few people get COVID after vaccination. Of those very, very few people that get, like, let's say 5%, of those 5%, very few carry it. Very few actually have enough actual virus in their nose to give it to somebody. And if the somebody is vaccinated, their chances of getting it, again, are very, very low. So a vaccinated person with a vaccinated person has an incredibly small chance to give it to each other. It's not zero chance, but it's extremely low. And that's why the CDC changed their rules about vaccinated people and masks. So that now, on the right, we see that vaccinated people can do pretty much everything unmasked. On the left, we see that the CDC is still advocating that people who are unvaccinated continue to do social distancing, risk mitigation behaviors, including masking. The decision tree for this is, so you say to yourself, okay, I sort of want to follow CDC directions, right? But what about, I'm not like everybody in the United States, I'm my own person. How should I make decisions about my behavior? And this is the way I think about it. If you're going to be meeting with somebody, the first thing that you want to know is, are they fully vaccinated? If they're not fully vaccinated, then you go a different way on the decision tree. If they are fully vaccinated, then you say to yourself, am I high risk? Are they high risk? And what is community transmission? So let me get into each of those for just a minute. What is community transmission? Right now, we are blessed in Massachusetts, because we're in a land of smart people, to have incredibly low community transmission. Yesterday, the state reported 33 cases. Now, maybe it was 50 and maybe 100 people didn't get tested, but those are incredibly small numbers out of 7 million people in Massachusetts. 33 reported cases. So this is what the graphs look like. I love graphs. So you can see, if you look at it from December 1st, you can see that it looks good. If you look at it just from June 1st, you see it looks spectacular. I mean, it's just such small numbers. So your chances so our community transmission right now is really low. I would tell you something else if you were in Missouri, but in Massachusetts, you just have to factor in, what is my chances of going to the store today and running into one of those 36 people, right? It's not very high, because again, like I said, we're in a town of smart people. This is at the Museum of Science, where their signs say mask friendly. I just love that. And even the dinosaurs are wearing masks. So, when you're in a smart town with a lot of vaccinated people, the community transmission rates are low, and you can factor that in. You do need to factor in whether you're higher risk. And that it's the same categories for getting severe COVID that we've known about for most of the last year, which is people over 65, people with chronic diseases that have affected their immune system or their organ system. And now we have to add in the immunosuppressed, because people who are immunosuppressed, like people who are on chronic methotrexate or people who are on chronic high-dose steroids, not an occasional steroids for poison ivy, but chronic steroids, or people who have had organ transplants, or people who are on certain medications for MS, they have to consider themselves immunosuppressed in a way that may affect their potential to get COVID despite vaccination. So if you are immunosuppressed, if you are high risk with medical problems, you consider yourself at higher risk to get serious COVID. If you are immunosuppressed, you may not be at higher risk to have serious problems with COVID, but you're definitely at higher risk to maybe not have the vaccine be as effective. So you need to think about those two things in making decisions. Basically, if you are vaccinated, fully vaccinated people present very, very low risk to you at this point, because again, they have a very small chance of catching it. They have a very small chance of carrying it in their nose. They have a very small chance of trying to give it to you, and you have a very small chance of catching it. So basically, vaccinated people with vaccinated people, pretty darn safe. The only people that are really a small risk to you are unvaccinated people. And how do you factor what a small risk is? Your inherent risk to get serious COVID and their risk of being your risk of being immunosuppressed. Those are the two things to really think about in addition to community transmission. So if you are vaccinated, it is really very low risk for you at this point to get together with vaccinated people in any context, indoor, outdoor, whatever. It is low risk for you to go to an indoor movie theater. It's low risk for you to get your hair done. It's low risk for you to eat indoors. It's low risk to sing in a choir, go to church, or work out in a gym. It's not no risk, but it's low risk. But so you want to wear your mask, right? Oops, I thought I had another one there. Oh, but if it is unvaccinated, it is less safe for you to do any of those things. It is less safe for you to go to the indoor theater or get your hair done. And if you're going to do those things, first off, I think ethically you should tell people you're not vaccinated. And second off, you should be sure and wear your mask right. Because masking and social distancing are the way that you should continue to run your life if you're unvaccinated. As to kids are basically, if they're under 12, under 11, they are unvaccinated because it's not authorized for them yet. So that means that kids are mostly now getting COVID from adults, from unvaccinated adults. Now, we are incredibly lucky that it's continued to be true that with children, COVID is generally mild. And it's very, very, very few deaths. But it is, incredibly disruptive to the family. It's very scary. You don't know how many kids are going to get long haul. A few kids do end up in the hospital, and a tiny few kids do end up dying. So they should really stay masked in risky situations. And that means situations with unvaccinated people. They are not they're like almost no risk from vaccinated people. They are definitely at risk from unvaccinated people. All right, I just want to spend the last part of our time here, and then I'll answer any questions that we have, talking about what I feel like we've learned from all of this, because, who was it? Roosevelt or Jefferson or somebody said, if we don't learn from our past history, we're doomed to repeat it. So there's a number of things that I've learned from the study of epidemics in the past that I actually find reassuring. Some people find them depressing, but I find it reassuring to know that pandemics follow patterns. Emergencies, doom-ridden incidents follow certain patterns. And maybe we could learn from this and try to prevent them in the future. That there's always clues and there's always people that ignore it. That diseases usually spread along travel paths, like airplanes or trade routes. That as soon as the widespread infections become obvious, there's huge outcries and blame and finger pointing and endless recriminations that people are doing it wrong. There's always suspicion and paranoia. There's almost always racism about the place where the disease may have originated, whether it's right or wrong. And we certainly are seeing that with all the Wuhan questions. There's often shame or judgment of the people that are ill. And I've written about the fact that my own extremely safe 25-year-old son got COVID for absolutely no reason. And without fail, people ask me, what he did wrong. He went to CVS wearing a mask. I'm sorry. So there's always shame and judgment aimed at the ill. They always show schisms in society. Everything that we've learned about equity and inequity in this pandemic, we've seen before in prior epidemics, particularly along the lines of racial and class disparities. At the start of pandemics, just like wars, people expect the bug or the war to behave like the previous one. And that's almost always wrong. There's always surprises about every new pandemic. With this one, they happened very quickly. We learned very fast, but they were very astonishing to learn that there was asymptomatic transmission. That changed everything. And that's not the case with the previous COVID coronavirus pandemics. I'm sorry, not pandemics, epidemics. And it was also not true with influenza. And that's one of the reasons that we got fooled. Usually with influenza, you get super sick. You're sick that day. Everybody knows it. You're coughing on the TSA officer. It's very clear. Here, you just breeze by the TSA guy and you make him sick without knowing you're sick. It's a silent transmission. There's almost always a poor political response, and there's usually tremendous harm in the responses. A lot of times pandemics are ignored or never even named. For the President of the United States never mentioned AIDS. The President of the United States never mentioned Spanish influenza. States, neighborhoods, and towns make decisions. There's always a push and pull between voluntary and enforced hygiene. I think it's important to know there's always been anti-maskers and anti-vaxxers. There's always been conspiracy theories. It's always a fight about whether the schools should be closed. A great piece of wisdom I've learned over the years is we only fund what we fear. Thank God we got so much funding for this. But it does usually it takes a while for that to happen, and I will give credit where credit is due. The vaccine funding was fantastic, and it helped the science save us, which is the most important lesson of all, is that the science is what will save us. You got to trust the science and the scientists. We need to plan for the next one. It's not over, but we're better. And as always, these are the true heroes. So thank you so much for listening to me pontificate. And I'd be happy to answer any questions, should there be any. And I'm just trying to stop my share.
That's fine. You can leave that. I was like, I love that cartoon, Doc. That's an incredible message there. And we are thankful to all those doctors and nurses that work tirelessly.
And pharmacists.
And pharmacists, thank you, that work tirelessly to assist in this pandemic. One question I have for you is that if somebody has an immunocompromised immune system, due to special needs and such, and the person is fully vaccinated, does that person need to worry about a person that's not even though the person is vaccinated? Does that person, even though they're fully vaccinated, immunocompromised somewhat, do they have to worry about wearing a mask or not wearing a mask, in your opinion?
I think they need to talk to their doctor to find out their own particular level of immunosuppression.
Okay.
But I think people need to be cautious because depending on the level and type of immunosuppression, they might be at more risk and they may need to still stay masked.
Okay, thank you.
It's something that we're studying a lot and as fast as we can, but we don't know yet.
Being an oncologist and dealing with patients, do you recommend your patients to wear masks around people as well?
Again, it depends on the level of immunosuppression. A breast cancer patient that's 3 years out and is just taking some tamoxifen, no. Somebody that's in active chemo, absolutely.
Yeah, so we are recommend as a pharmacy, we consider ourselves as a medical facility. We are asking our customers that come in to continue wearing their mask. We're not forcing it, but we're asking them kindly to continue wearing them, just because we have patients like that in the pharmacy that do walk in on a daily basis, and we have children under 12 that have not been vaccinated yet. So
right.
We get some pushback on that aspect, but we're just trying to do the right thing. I mean, I know who wants to wear a mask, but there are still vulnerable people out there that we have to do, so.
Good for you, and I can see how that's hard and will get harder.
Audience, any question? I could unmute you if you have any questions, or write down in the chat. We'll,
Yeah, I have another question, Doctor. You touched a little bit about it, but not much. What about the booster? What's your feeling on the booster shot down the road?
I think it's possible, maybe even probable, particularly if a variant comes through that has more escape than we've seen so far. I've heard they're working on one that combines COVID and flu. That would be awesome. And we just go in, and get our yearly flu-vid shot.
Exactly. Now, from your, obviously a lot of reading and studying, so far we know that the virus is out at least good for 6 months. Have you seen anything that gives it a longer time right now?
Well, we can only know for as long as the first shots were given. So the first shots were given in July.
Okay.
So we have 11 months of follow-up on those people, and it seems to be good.
They're still showing antibodies and.
Yeah. But that's, obviously just the small group of people that were in the trials. But there's been no signs that immunity wanes in any terrifying way after the vaccine. But, obviously we need more time.
And the numbers have been so incredible. I mean, obviously, as I'm sure like you, I watch the numbers on a daily basis. It's just been incredible how, that trajectory is downwards amazingly. 33 cases is still a lot, right? We still don't want any cases out there, but it's amazing from the hundreds of thousands that we're dealing with.
That's right. When you go from 4,000 a day to 33,
That's amazing.
Hallelujah.
What's your feeling on, so being that we're in the pharmacy field here, and, we see people who had COVID shot number 1, COVID shot number 2. Some people were very sick with the first shot. Some people were really sick with the second shot. Some people weren't sick at all from either shot. What's your take on that? Have you seen anything with people who had COVID versus didn't have COVID?
Well, they say that the side effects are worse in young people and worse in people that have had COVID before. But worse is relative. I mean, I think it, you know, almost everybody gets a sore arm, but really when you come down to it, only about 50 or 60% of people get whole body side effects, which means 40 or 50% don't. So for instance, my 25-year-old son, who's young and had COVID, had no side effects at all. So he fell into the good part of the 50%. I think, you know, we're going to continue to see small numbers of other kinds of side effects, but, you know, they're going to be in the hundreds compared to the millions of shots. So again, when you weigh the temporary side effects versus long-term immunity, for most people, it goes way in the direction of vaccine.
I mean, I'm happy to report. I mean, we've given all 4 locations of ours. We've given a lot of vaccines out there, and knock on wood, I don't think we've heard of anything serious
Right.
of a side effect besides the 10 to 30 hour period that you may get after a second dose of vaccine, possibly after the first if you had COVID, of just a mild case of the flu. And it's amazing. Like you have it, and then boom, goes away. It's like the body's said, I'm up, I'm ready, I'm ready to roll. So it's
Ready to roll.
Exactly.
Yeah, got that army lined up.
Exactly. So, you know, it's which has been very encouraging, obviously. And, you know, that's what with obviously with us, it's the J&J and the Moderna vaccines that we've been given. But
That's fantastic.
same thing with the Pfizer as well.
That's fantastic. Good for you guys. I mean, I hope people recognize this is like the miracle of our lifetimes, that this has happened. No scientist or physician that I knew in March ever predicted that this could happen, that you could have such an incredibly effective and reasonably safe vaccine in 11 months. I mean, it is the miracle of our lifetimes.
Awesome. Well, if there's no further questions, incredible, informative presentation, Dr. Schoenthaler. We appreciate it.
Thank you so much.
Sure, no problem.
I thank ActonTV for doing it live on their YouTube channel, but we will have it uploaded in our YouTube channel hopefully by next week. And you know, I think we're gonna take a couple of months off from presentation. We'll be back in September with our lecture series, and hopefully it'll be live. So
Great.
so, you know, thank you so much again, Doctor.
Sure. Thank you too. Thank you guys for attending. That was really well.
Thank you so much.
Thank you.
Thanks
All
for
right.
joining us, audience. We appreciate it.
Thanks
Take
a
care.
lot.
Have a good day.
Bye-bye.